do a little introduction here. Welcome to today's BHIPP crisis training, the emergency petition process, and this will be presented by Dr. Sarah Edwards and Stephanie Knight. I'm Megan Crosby-Budinger. I'm the program director of Maryland BHIPP, and today's training is supported by e-COVID funding that we received through a SAMHSA grant to support efforts to address mental health needs during the pandemic. Before we get started today, I just wanted to draw your attention to a few features of the WebEx training. We will be recording today's training, and we'll be sure that the slides, handouts, and recording will be available on our website. If you have any questions during the training, please feel free to use the raise hand feature, or you can drop your question in the chat, which we will be monitoring. And if we don't answer your question right away, we will be sure to leave time for questions at the end. Let's see here. We do have, so one of my teammates, it looks like, is going to be joining here, Naomi, and she is going to be, let's see, looks like she's logging in now. So she is going to be putting a pre-knowledge survey question in the chat. And we're hoping that folks wouldn't mind taking just a few moments to complete that before we get started. Let me check on that because I don't see that here. Hi, Naomi.
Hello.
Hi there. I was just telling our attendees today about the pre-knowledge questionnaire. Could you go ahead and put that in the chat for everyone now?
Yes, ma'am.
Thank you. So this is just a single item question. We're hoping everyone can complete that before we get started. It just helps us ensure that our trainings are as good as they can be. So I'll give you just a moment to look at that. All right. So without further ado, I'd like to turn it over to Dr. Sarah Edwards, who'll be leading our training today.
Wonderful. Well, thank you, everyone, and I really appreciate your attendance. Looks like it's a beautiful fall day right now, so I know you could be walking outside taking your lunch break, but we appreciate you coming and joining us today to learn. So I'm Sarah Edwards. I'm a child and adolescent psychiatrist at University of Maryland. I have the pleasure of being the medical director of BHIPP, as well as the director of our division and medical director of our services here at University of Maryland. And I'm really pleased to introduce my colleague, Dr. Stephanie Knight. Stephanie, why don't you take a moment and tell everyone about yourself?
Hi, good afternoon. My name is Dr. Stephanie Knight. I'm one of the psychiatrists in the adult section of the School of Medicine Department of Psychiatry, and my primary role for the last going on 7 years is the chief of psychiatry at University of Maryland Midtown.
Stephanie is everything adult psychiatry. And so I was very excited when she agreed to tag on and help me co-present because she has such an important piece of information regarding our young adults and adults who end up being hospitalized and what that kind of process looks like. So I think you'll be having a lot of information, not only about emergency petition, but really combing through some of these ideas and concepts about what does it mean to be involuntarily committed and what does that process look like. So with that, let me figure out, are we okay with your chat question? Did you get enough responses? Can I get started, or do you want me to wait?
Let me check really quickly.
But let me figure out how to share. What are you guys looking at?
So I am able to see your slides, and then I know people can change their layout. So I have slides, and then I have some faces up at the top of my screen.
Okay, are you seeing, I have mine in like presenter mode? Is that what you're seeing, or are you seeing just the regular slides by itself?
I'm seeing the slides here, your title slide.
Okay, so not the presenter mode.
Right, right.
Okay. And then there is a short little video. Is there a way, on Zoom, there's a way that you enhance so that the audio is okay? Is there a way to do that on WebEx?
I'm not sure if there's a way to enhance it, but we should be just fine to play the video. And if we have
We get to it.
if we have any difficulties, we have a member of our IT team who can hop on and help us with that.
Wonderful. Okay, great. So we are going to be talking about what to do during a psychiatric crisis, and really understanding from our state perspective, Maryland's evaluation process. Let me make sure I can advance the slides. There we go. I don't have anything to disclose, and Dr. Stephanie Knight doesn't have any disclosures as well. Who we are. So we are Maryland BHIPP, and that's Maryland Behavioral Health Integration in Pediatric Primary Care. And we are a child psychiatry access program that supports the capacity of primary care providers in Maryland to manage pediatric mental health concerns. And so we offer a lot of different things. We offer free telephone consultation. We have lots of wonderful resource and referral support, training and education opportunities, just like what we're experiencing right now. There is something called Project Echo, which is a web-based longitudinal learning project. And we are also able to offer care coordination. And then a very unique aspect of our telephone access program is our social work co-location. And so in collaboration with Salisbury University and Morgan State, we have social work interns co-located in many primary practices across the state. So we're very excited to be able to present everything. Our partners and funded, we are funded through the Maryland Department of Health, the Behavioral Health Administration, and it's in collaboration with University of Maryland School of Medicine, Johns Hopkins University School of Medicine, and then Salisbury University and Morgan State University. So with that, let me kick it off. At the end of this, we really hope that you'll be able to describe, what are conditions that would necessitate Maryland for you here in the state of Maryland to do an emergency petition? What does that process look like? And have you to be able to kind of mentally really outline that, then learn the differences between what is an emergency petition and what does a psychiatric certification process look like, and then describe what happens to an individual if they are involuntarily committed to the psychiatric unit. All right, so everybody here, many of you who are signing in are clinicians. It's great to see. I saw lots of wonderful social work colleagues logging in, and we're faced with this. What do we do? And even if you're not a clinician and you're joining us, we're all going to be parents, friends, neighbors, family members of sometimes we're worried about the people in our lives, and we're worried they're experiencing. We know that something's not, we're worried for their safety. We know that they're having a psychiatric emergency. Maybe they told us, hey, things have just been so rough, I want to die. Or maybe it's the person who's not necessarily telling us that, but we know that they really have started to not take good care of themselves. They're not eating. They've mentioned some concerning comments about being worried about somebody poisoning their food. And then what do we do if they won't voluntarily go and seek some sort of evaluation? So that's here in the state of Maryland. We have the emergency petition process. I can only speak to the state of Maryland. This exists, we have state laws and COMAR laws that really regulate what this looks like. So if you trained in a different state, lived in a different state, you might be familiar with different terminology, but we're focusing today on Maryland. And so that's an important thing to always remember when if you do go to practice and move away, make sure one of the first things you understand as a clinician is what are the state laws like here. So in Maryland, an emergency petition enables an individual to come to the emergency department for evaluation. And that's if there's concerns that they have a mental health disorder and are demonstrating concerning behaviors. So the language is that they're presenting a danger to life or safety of the individual or others. So this is not the same thing. Sometimes we misconstrue and our terminology gets a little blended. Sometimes people say, oh, they're on a 72-hour hold. That's not what this is. And this does also, really importantly, does not guarantee that an individual will get admitted to a psychiatric admission unit. So all this is doing is saying, this individual, there's enough data and we're concerned enough, they will be brought to the closest emergency room and they will have an emergency evaluation. And then the disposition after that will be determined. So if I emergency petition a patient of mine, I'm really concerned and they're refusing to go to the ER by themselves, we'll complete this process, but all it's going to do is make sure that they go to the emergency room for an evaluation. Does not mean admission. So that sometimes gets complicated in our kind of language and terminology. And why this is so important is this is really helping to assist individuals whose mental illness sometimes really makes them unable to recognize their need for treatment. And Dr. Knight added this wonderful video, so let me play this to kind of better explain this concept and this fancy word here. So let me just, hopefully I'll turn up my volume as loud as possible. Can you hear that okay? Megan, can you give me a thumbs up?
Anosognosia
Yeah.
is a common symptom of severe mental illness. It's a lack of insight, impairing one's ability to recognize their own illness. This inability for someone to see their own symptoms is one of the reasons why people with severe mental illness, like bipolar disorder or schizophrenia, do not seek treatment. Without awareness of their illness, this refusal is perfectly rational to them. Anosognosia is extremely widespread. In fact, 50% of individuals with schizophrenia and 40% with bipolar disorder display anosognosia as a symptom of their illness. This means nearly half of those with severe mental illness, SMI, sometimes do not know they need treatment. This lack of capacity to recognize one's illness is not the same as denial. Research involving brain scans reveals that when people experiencing anosognosia are asked to think about themselves, they show significantly poorer activation in several key brain areas than those without this condition. Anosognosia is a neurological difference, not a choice. In recent years, discussions of self-care have been brought to the forefront of mental health conversations. Talk therapy and mindfulness can treat some mental health conditions, but the treatment of severe mental illnesses often requires more, including medication. For people unaware of their mental illness, self-directed care can mean no care at all. For others, the only care received comes from family members who may be full of love and compassion, but aren't trained to replace doctors or crisis teams and shouldn't be asked to fill those roles. This unfortunately means many who lack appropriate treatment end up in a revolving door of incarceration, hospitalization, or homelessness. A system focused on those who are able to seek voluntary care leaves many people with the most severe mental illnesses out in the cold. For many with anosognosia, compassionate court-supervised treatment plans, like assisted outpatient treatment, can provide the last hope when all else has failed. It can also help people who experience anosognosia keep their hard-earned gains while returning more quickly to their communities. For those too ill to seek help, we have to be ready to intervene with compassionate care. Treatment Advocacy Center works tirelessly every day to improve access to treatment and to improve outcomes for families affected by anosognosia. Our work is far from over. We need advocates like you to support people who experience anosognosia in getting the help they need. Visit our website to learn more about anosognosia and how you can help remove barriers to treatment.
Okay. Wait. There we go. It's always hard to advance that one slide after a video, but I thought that was a wonderful synopsis of why this emergency system exists, right? So the individuals with severe mental illness, who it is part of their illness that impairs their ability to acknowledge that they might need help. And this is a system that we here in Maryland in our society can start and engage that way that we can ensure that these individuals are evaluated and then treated, and really kind of give them that leg up. So this is an important piece. So back to kind of that criteria, we're looking at here in Maryland, you can do an emergency petition when you're concerned that an individual has a mental illness. And so it's important to say that this is not just for an individual who might have intellectual disability or only substance use, but kind of looking at comorbid conditions as well. And so that it's really that whole idea of not just to focus in on substance use only, but there's something else going on in addition. And that we're concerned, right? We're concerned that they might be danger to themselves, to others, and that this could be something very active like assaulting, damaging property, threatening to hurt other people. But frequently the piece that can get a little bit unrecognized is when dangerous behaviors can also be very passive. It can be for that individual who's not eating or drinking, not taking care of their physical needs. Neglecting medical conditions, we don't see that so much in the children arena, right? Because we have parents and guardians, but Dr. Knight sees that a lot with the adult or young adult patients. So this is when somebody who might have diabetes or such a horrible infection doesn't have the ability to recognize that, they need to be taking their insulin. They have to be taking that antibiotic. And so it's important to think of both, yes, the assaulted person who's really threatening or able to verbalize, no, I'm thinking of hurting myself, but also those kind of more passive situations, and make sure that we're always thinking about both when considering to completing an emergency petition. And so I kind of came up with a little decision tree here. So that first part is you're concerned about your dangerous behaviors, reason to think that they're presenting a danger to the life or safety of themselves or to others. And then what happens next? So the next phase would be you have to complete the emergency petition, and that can happen in different ways. If something requires immediate attention, you can call police. You can also call a crisis like 988 to call a crisis unit. And if there's a mobile crisis provider, they could come and evaluate the situation. So if it's so urgent and you're going a police route, those individuals can go ahead and complete an emergency petition. The other route that's not frequently used, though, is that family and friends, if you're concerned, they could actually go to the court and complete an emergency petition. And then a judge will decide whether or not it meets that criteria, that there's sufficient evidence and concern, and then they will execute that emergency petition. The next step is that, again, as I said a few slides ago, the only thing an EP does is it brings an individual to the closest emergency room for an evaluation. So the next step would be that evaluation part in the emergency department, and then that behavioral health evaluator, which frequently social workers, licensed clinical therapists, sometimes psychiatrists, depending on where you are in the state, will do that evaluation, and then they're making that determination for disposition planning. So typically that means, do we admit or do we not admit? So the three ways, as I mentioned a little bit before, that somebody can be emergency petitioned would be first through law enforcement. So police can actually serve as the one to complete the EP, and I'll be showing examples of this as we continue, or they're involved because they're transporting that individual to the emergency department for evaluation. The other part is that you could be a qualifying clinician to complete an emergency petition. And I think that's why many of us here who have joined today, you're in the roles of seeing patients. So this could be physicians, psychiatric nurse practitioners. It is important to recognize that it has to be a psychiatric nurse practitioner. Family NPs or other types of advanced practice providers currently, according to the most current Maryland state law, are not able to complete an emergency petition. Psychologists, clinical social workers, LCPCs, and then LMFTs as well. And so they have to personally examine the patient. So on the first block, when we're looking at law enforcement, if a police officer is called to a situation, they have to observe the evaluee or the patient, the person that we're concerned about. They don't necessarily have to see all of the behavior that somebody else might have alerted to them that's concerned, but they have to observe the evaluee and determine whether or not they meet criteria. For the clinician, personally, you have to observe that the patient and then complete the emergency petition. And then the third route that you can do, again, is this is typically done by concerned family members, is that you request an EP directly from the court. So you complete this form, you would take it to the judge, the district court, and they would hear the testimony around that and decide whether or not that the evaluee meets that criteria. And if they do, then law enforcement then has the emergency petition, and police officers would bring that individual, they have up to 5 days to do it, and they would bring that individual to the nearest emergency department for that evaluation. So this is the form. I have the link in here. It is now a PDF fillable form, which is really nice. Years prior, we were always, photocopying and filling it out, and this is really lovely. So next slide here is the enlarged part, and I'm going to break down the important pieces. And even if you think you're never going to fill out an emergency petition, if you're seeing patients, pull this up and just make sure you're aware of it. It's kind of like practicing why we renew our BLS. You got to practice for emergencies, because when they happen, you panic, you have lots of adrenaline, and you kind of need to think through what you're doing. The only way we can do that a little bit more easily is if we practice. And so to actually take the time after this at some point and, pull it up and see what this is like. So the first part is about, completing, you're the petitioner, right? And so you're going to put your information in there and make sure that you meet that criteria. The next part is, who are we evaluating? Who are you asking to have that EP on? So typically that's your patient, and it has all the demographic information. And you just go ahead and, complete that. The important piece here is that when you, as a clinician, are describing, this is really important. Basically an emergency petition is taking away, it's somebody outside is determining and forcing that person to go to the emergency room and have this evaluation. And frequently, as the video showed, against people's wills. Sometimes individuals don't have that ability to know that they really should, that it is in their best interest to have this evaluation. So your job is to really be very specific and draw out and give that full portrait of why you're so concerned that you're completing this. Why there's a disturbance in their mental functioning, their mental status that is so, so serious that we're saying they need to go to the emergency department and be evaluated. So you don't want to be vague. You don't want to say something like, for example, patient is paranoid. I don't know what that means, right? They're paranoid that they think they're never going to, that their mother might be talking about them. They're paranoid that their friends are talking about them. Or you get very specific, and this is what we need you to do. They're paranoid that somebody's poisoning their food. They have lost 5 pounds, have not had any food to drink in 3 days straight. That's very specific, factual information that adds support as to why police are going to go and pick up this individual and have them have that emergency evaluation. There is a question that notes about firearms, and Dr. Knight will talk a little bit more about that in current laws in Maryland. So this is the second page when you link to this for the emergency petition form. So I just put this here. It gives a little bit more information and some reasoning, but so that you can see that there are 2 pages. Now this is the tricky part. When I first started training 18 some years ago, I guess, not only do you have to fill out an emergency petition, that form that we just talked about, but you have to also fill out another form. And this is called certification by a peace officer. And so the police officer will complete the first part. That's what they are saying, they go through that, but you have to also, as the clinician, fill out that bottom piece right there that says certification by other person qualified and peace officer. So you have to complete that part. So it's 2 forms, and when you Google them and you look under Maryland emergency petition, they don't always populate right next to each other. It's kind of it's not kind of, it's very confusing. So I put together a little roadmap here to help break it down. So if you're a clinician filing and filling out that EP, the first thing is you got to fill out the form and you got to describe your concerns in detail. The second form you have to complete is that certification by they call it peace officer or police officer form. And then the next piece here is that you would call 911 and ask police to come up and pick up your EP. And then they frequently will come. Now, here's something, we have exciting up-to-date report to let you know that now this can be done electronically. But in the past, what would happen is that I would be in my office and I'm waiting for police to come. So I can give you horror stories of being in an ambulatory clinic. And in urban Baltimore City, there's a lot of competing pressures from police officers. So they're attending to higher levels of emergencies, and I would be waiting for hours and hours. I've had to sit with trainees at times, and we've been here till 11 o'clock at night because Baltimore City police are very, very busy. So the other option, besides having police come and pick up that emergency petition, is that you could go drop it off at a police station. It has to be in the jurisdiction of the patient's location. So where you know the patient is, where their home is. So that part's important. Again, now the law has changed and you can do this electronically, and Dr. Knight will mention some more specifics about that. But in the old days, as prior to October, what would happen is if I was a clinician at home and I got a concerning call and I'm worried about my patient, if I fill out an emergency petition and they live in Baltimore City, but say I live in, I don't know, Howard County, Montgomery County, I would have those police, if you call the local police, they're going to say, Montgomery County is saying, I'm not going to come to drop this off in Baltimore City. You're responsible as that clinician to drop off your emergency petition in the jurisdiction where the patient is located. So we have like old stories of some of our office therapists, you know, driving to Baltimore City later at night than they wanted to be coming to make sure that they had, you know, provided the emergency petition so that patient can be appropriately taken care of. And then the police will come and they will find, you know, the evaluee, and they will bring them to the closest ED for evaluation. So that's kind of like the roadmap. Now, some lessons learned from having done this for a while is that whole part about emergencies. We have to practice and be prepared. And so have access of these forms. In the old days, you know, have the forms printed out and on you. Now we have everything, it's fillable, but know where those websites are and make sure you have that link. I think it's really important in an office setting to have a policy. What is the procedure when a patient is in crisis? What are you going to do? Think through that so that it's when it happens, this will make it a little bit easier and more consistent and be handled in the best manner possible. It takes some time to complete the forms, right? And to have either the police pick it up or you drop it off, or even if now that it's great news that this can be done electronically, you got to make sure that you have the computer that has the internet and can do that, or scan the, you know, whatever it is, you just have to have that plan in place. So what you're saying is so important that you're, you know, in essence, having the police pick up your patient, you need to be available. Your concern and information matters. It really does. And so make sure that you give them your cell phone, write it on the EP, so that when they finally are having that behavioral health evaluation, that the evaluator and the ED can call you and get more specific information. That little part in the EP, you can add extra paper, that's fine. But there's nothing like talking in person for that collateral. That can make the difference. That can make a big difference in deciding whether or not that person, what is the best and most appropriate disposition plan. And keep in mind that an EP, what is the function of an EP? Concerning behaviors, going to an ED and getting that evaluation. That does not necessarily mean that they're going to be admitted to the psychiatric unit, right? So they could easily be discharged and come back to you the next day. And you have to just be thinking about that too. Because I think a lot of times, if you don't fully understand the process and the whole point of an EP, you might be thinking, okay, I'm done with them for a couple of days. I don't have to worry. I can focus on something. No, they're your patient, and they very well might be evaluated. And at that time, it might be decided, okay, they can come back and see their outpatient providers. And so you just have to be thinking about that and be prepared. I guess it doesn't matter as much because now that we can do it electronically, but another kind of lesson learned tidbit is I did have a therapist who lived far away. She was in Montgomery County. She drove up to Baltimore City, dropped off the EP at the district police station, and they said, "Oh, ma'am, no, you can't. This isn't correct. You use blue ink." Who knew? There's nothing that completely states that you have to use black ink, but if you're going to be doing it in person, my tidbit would be, please, I guess, use black ink. And so she had to beg them to get onto a computer to download a new EP form so that she could fill it out in black ink. And it was just, kind of one of Murphy's laws. It was quite the experience for her. So I just take all those kind of, unfortunate lessons learned and make sure that I always share that information with everyone. But with that, I'm very pleased to hand this over to Dr. Stephanie Knight, and she'll kind of take us through the next process of what happens. Stephanie, do you want to upload it, or do you want me to advance your slides?
Whatever is easier, it doesn't matter.
Okay. I have it right here, so I can just keep clicking.
Okay, sure.
Okay.
Before we start with this one, I wanted to add 2 lessons learned, I think, to what you've already presented. And that's that at the very bottom of the certification by peace officer, Dr. Edwards pointed out that, yes, thank you.
This one right here.
Yep. And so at the very bottom, what is cut off a little bit by the slide is that there is another place on the form where the peace officer has to sign, because a critical and actually a required part of the process of EPing someone is that the police are serving the petition. And many times, they're filling out that top. You fill out the certifications by other person, but then the duty of the police officer includes a description to you of the ramifications, that you're restricting the person's civil liberties by requiring that they get an evaluation against their will if they're not consenting to it. And they're supposed to explain to you as the EPing clinician, they're supposed to explain that to you. And then after they do that, they need to sign the very bottom of the form in a second location. So there's actually 2 places on that same paper where they can sign. I do have a fillable PDF version that's combined the first and second pages with the certification by peace officer, because that third page, as Dr. Edwards pointed out, often gets left out. So I'll share that with Megan, and then we can send it out to the group. So that way there's less of a chance of losing that third page in the process. The other lesson learned, I think, which is really important, and which happens with some frequency, is that without police being involved in the process in serving the petition and bringing the patient to the ED, if you just fill out the EP paperwork as the concerned clinician and you don't involve police, let's say the person is in your office and you have transported them in whatever way, walking or car, you've gone with them to the ED to facilitate the process, and you have the EP paperwork in hand, it's not valid. If you don't employ the police to serve the petition and have them be the ones to bring the patient to the ED, it's not a complete legal document. And if the person wanted to leave the ED, then they could do that. There would be nothing holding them or requiring that they be assessed without police being involved in the process. There were some attempts to modify that in the past, but they didn't make it through the legislature. So as it currently stands, police have to be the ones to both serve the EP and transport the patient to the ED. You can certainly go with, but they have to be part of the process. It's not binding otherwise. Okay, so The emergency petition process is actually one of the older risk mitigation based statutes on the books in our state. And it's really one of the better ways to get people into care if they're lacking that insight or awareness into their condition. Under the second bullet point, you'll note that EPing someone doesn't require that they're imminently dangerous to themselves, like they're not, they don't have to, for example, if you have someone who's been self-harming, and you're concerned that that might escalate into attempts on their own life. You don't have to see them self-harm. You don't have to have witnessed, a scratch that they made earlier that day or an incision. Just knowing that they are planning to do that or having thoughts of doing that, coupled with your exam of the patient, is enough. They don't have to be standing there with whatever tool they were using to self-harm. And then the firearm question at the bottom of the EP form, the very last question is, asks you to provide information about firearms or weapons that the person may have access to. And that is specifically related to a series of very unfortunate incidents many decades ago where someone needed to be petitioned, but they had a firearm in the home and the police were unaware of that, and an officer was killed in the process of trying to petition that patient. So knowledge of firearms and weapons absolutely is a critical piece on that form, but it's okay if you don't know. That's not going to like reduce the impact of the EP, but it is helpful if you do know to fill out that portion of it. If you don't know the answer to that particular question, it's okay to write, unknown, but leaving it blank is what you would want to avoid. And as Dr. Edwards mentioned in the 2022 legislative session, then we're now able to transmit EP paper, both complete it electronically and transmit it electronically. But how that looks in each of your systems could vary. The statute isn't so prescriptive in terms of the logistics of that, but it is allowable. So you could ask, if someone is not imminently dangerous, but they have some concerning behavior that potentially is dangerous to themselves or others, but they don't want to go at that moment, couldn't we just wait until they're a little bit more agreeable, or until their, trusted older sibling could talk them into just going ahead and coming with them? Or if you only get the right person, if you only say the right things, then maybe you could convince them. I think these are the things that we all, as humans, kind of go through. We really want the least confrontative process. However, timely treatment really is critical. And it goes beyond the obvious, like you want to minimize the risk as soon as you can. It goes beyond that, because what we know in a variety of mental illnesses, that actually there are a lot of things happening in the brain when somebody is destabilized, and there's actual brain damage that is occurring as their symptoms go untreated for longer periods of time. And so for patients with psychotic disorders, as you can see on the slide, if they go from 1 week of untreated symptoms to 4 weeks of untreated symptoms, their symptoms are going to be more than 20% more severe. And we know in a variety of kind of the major diagnostic criteria or the major diagnostic illnesses, that the longer someone is struggling with their symptoms, the more difficult it is to really treat those symptoms effectively, and the harder it is for them to re-achieve their baseline. So getting them into care quickly is of most importance. We also know that we can decrease some of those social determinants of health that make it so hard for people to be living with their illness as opposed to suffering from. So when you get them treatment earlier, then rates of homelessness and incarceration also go down. So here's another decision tree courtesy of Dr. Edwards. So when someone has been brought to the ED on an emergency petition, then the responsibility shifts from you as the petitioner to the folks working in the ED setting about what to do with this person based on the evaluation. And as Dr. Edwards pointed out, all the EP does is get them to the ED. The follow-up mandate related to like fulfilling the rest of the statutory requirements of an EP is that the person has to be evaluated by a physician within 6 hours of their arrival to the ED. I know that there's staffing shortages everywhere, and for some of our colleagues who live in the less populated regions of the state, there may only be one physician working in that ED, but it has to be the physician. It can't be another licensed individual. And that is because there are still a significant percentage of people who present to the ED who may not be medically stable enough to be safely treated on an inpatient psychiatry unit if that's what they require. For example, maybe they haven't been eating like what we've mentioned before, and but they have type 1 diabetes and their blood glucose is above 400. So the physician needs to be able to identify that and determine the treatment elements that would be necessary to maintain the person's physical stability were they to need psychiatric admission. So it has to be a physician. So once that person has been evaluated by the physician, then and deemed that there aren't medical there aren't medical causes contributing to the person's presentation, or if there are, then they're under control. Then the decision is, okay, what to do with them psychiatrically. And so if someone is going through that process, whether or not they needed to be admitted to psychiatry is really based on clinical exam and legal criteria. So the legal criteria for admission kind of are slightly different depending on whether or not the person is willing to sign themselves into the hospital. And we'll go over this a little bit more as we continue on. But long story short, if the person has a mental illness, you can see the bullet points on the right side. If that mental illness is treatable in an inpatient setting, if they understand kind of what they're signing up for, they understand that they're going onto an inpatient psychiatric unit where they're going to be evaluated and offered therapy and medications. If they are able to consent to that process and they understand how to ask for discharge, then they could be a voluntary patient. Oftentimes, these are folks who really hadn't wanted to come to the ED, but know that they probably just need to go ahead and sign in and just kind of see what the process, how it unfolds. They're willing to take medications. They're willing to engage with their treatment team, do interviews, get labs, things like that. If someone is willing to sign a voluntary but is adamant that they don't want to take medications, in this day and age, we're not going to admit them voluntarily because psychopharmacological interventions really are one of the primary means of treatment on the inpatient unit. And the person needs to be willing to provide continuous assent to treatment. And if they're not willing to take medications, that's not continuous assent to treatment. So they would then be shifted into that second category of people who might be involuntarily admitted. So admitted against their will to the psychiatric unit. That requires a little bit of a different standard because you're doing something against their will. So that makes sense. So if you're working in an ED setting and you're considering whether or not somebody needs to be certified, then you would be looking at someone who has a psychiatric illness, who presents a danger to themselves or others, either actively or passively, as Dr. Edwards mentioned earlier. They have to be unwilling or unable to sign a voluntary application for admission. And they have to have failed or not have available to them a less restrictive environment of care. So, for example, if someone could be safely maintained in a crisis bed, then you probably wouldn't be certifying, they wouldn't be certified for involuntary admission, because putting them behind a locked door is really the equivalent of a psychiatric ICU is the inpatient unit, right? So if they need ICU level admission, then that is a pretty high threshold of symptoms. If they could possibly safely be maintained in a less restrictive setting, that is always better. Because you can't sign out against medical advice from an inpatient psychiatry unit. There is no such thing. And so if they get on the unit and they want to leave, there's a somewhat elaborate process, which we'll touch on briefly. So anyway, it gets complicated quickly. So.
And I would just add, for the part about medications in kids, we frequently do have youth who come onto the unit, and we work with families and youth, and sometimes medications are not needed. So it's a little bit different when we're comparing what an inpatient unit stay looks like for kids versus for adults. So I just wanted to throw that in there.
That's a great point. Thank you. So this is the voluntary admission form. I know we're almost at time, so I'll go over these pretty briefly. This is the voluntary admission form that can be signed. This is the bottom of it. The top of it is where the patient signs agreeing to be admitted for treatment. And then the bottom portion has to be countersigned by a physician, psychologist, or a psych NP. This form is a different version of a voluntary admission. This is the voluntary admission of a disabled adult. This is a process that's existed since about 2018. And for people who have guardians of person, but who want to be admitted to the psychiatric unit and otherwise meet all of the criteria, in the past, prior to 2018, we had to certify them because there was nothing in COMAR that allowed for them to be able to maintain the right to sign themselves into care. And a guardian cannot, for adults, a guardian cannot sign someone in for inpatient admission. So we would have to certify people basically just because they had a guardian. And then there's a hearing process, which we'll touch on briefly. And they would inevitably be discharged by the judge because they weren't meeting this higher threshold of criteria that's required for involuntary admission. So now we can offer them a voluntary admission if they meet criteria and they have the capacity to sign that. But there is always a balance, and there's really that need for care. But you have to take that in the context of wanting to respect the patient's choice and preference and what they want for themselves, for their own life. So, but what we know is that if the illness goes untreated, then folks are really not living up to what they would consider their own potential. And so there's evidence from our own state, from the Medicaid data from 2012, that of the population of folks with SMI in our state, there's about 590 of them who accounted for 25% of all ED visits in the state that year. So 590 folks with severe mental illness, symptoms untreated, can't stick with care for a variety of reasons. They're really requiring a lot of intervention by a variety of people, many of you on this call included. And so getting them into care is really critical. And the question always is, if they were doing well, if they were stable, would they want to avoid treatment, knowing that it could change their course and their prognosis? So if they're not thinking about things kind of with all of their capacity to do so, then they might be making different decisions. And we don't want them to have permanent consequences as a result of that temporary state of being. So in terms of what happens once somebody gets onto the unit, I'll go through that quite briefly. So once someone is certified for involuntary admission, then there's a hearing process that happens. The reason that we wanted to touch on this briefly today is that there is a direct relationship between the quality of the emergency petition and the evaluation that happens in the emergency department. There's a direct relationship between that and whether or not the patient is able to be treated on the inpatient unit for a period of time. So if the EP process fails in some way, when we have to present to the judge why this person needs to be in the hospital for a longer period of time for treatment, then there's a chance that the judge might actually discharge the patient just based on errors in the EP process. And the statute allows for that. So anybody who's admitted to the inpatient unit is required to have a hearing with the ALJ, administrative law judge, within 10 days of their confinement. And confinement is defined as when they physically cross the threshold of the locked inpatient psychiatric unit. So that 10-day period doesn't start even if they're sitting in the ED for 30 days. The hearing won't happen until they're physically bedded on an inpatient unit. As many of you on the call may know, the hearings with ALJs currently are virtual and have been since the pandemic. Unfortunately, I don't believe that they're planning on reverting back to in-person hearings. There's consequences to that which go beyond this conversation. But once someone has to sit in front of a judge, then they could be released or retained by that judge. And it matters not what the clinical is. Sometimes if the technical process wasn't followed, we might still have to discharge them by order of the judge. So not everybody that gets admitted involuntarily ends up being civilly committed. There's a very small percentage, actually, because there are many things that happen between the time of admission and the time of them seeing the judge. Just for time, we can keep going because I don't. So hearings are at designated days at each facility in the state, and we're at a little bit of a disadvantage. There's a lot of history to this, but most involuntary commitment hearings are kind of the Office of Public Defender representing the patient, and then a lay person from the hospital, often from the clinical team, representing the hospital's interests and the need for treatment of the patient. And so lawyer versus non-lawyer in a legal hearing doesn't always feel like you're working with the same tools. And so there's a little bit of a disparity in that process, which can be interesting and challenging for the patients and the teams. So, but at the end of the day, the 5 questions that we have to demonstrate to the ALJ would be whether or not the patient has a mental illness, they require inpatient care, they're a danger to themselves or others, they can't be a voluntary patient for whatever the reason, and they've failed a less restrictive level of care. We often solicit input formally from outpatient treatment providers during the hearing process. So if you petition someone, you may be asked by the inpatient team to testify in their commitment hearing. It's not a requirement. You're not obligated to do it just because you were the petitioner, but the teams may ask for your formal input under oath. Oftentimes if we feel like it's a bit of a crapshoot as to whether or not the judge is going to require the person to be in the hospital. So there is a consideration of whether or not the person can continue to own a firearm related to whether or not they're civilly committed. And we're not going to have time to go into most of this, but please know that if the person is involuntarily committed, the judge has to decide whether they are a danger to other people, not themselves, but other people. And if so, then the judge can actually order that the patient be temporarily disallowed from owning firearms legally. So their name would go on a list that's maintained by the state, and they would not be allowed to purchase firearms in the official legal way.
And I don't know how much you want to briefly go through this. I think, Megan, are there questions in the chat? Because we can never see the chat. Should we continue or answer these questions?
There's currently no questions in the chat. I've been kind of keeping track of that. And we have about 5 minutes left.
Okay. I mean, this is very interesting, the extreme risk protective order. Stephanie, if you can give like a little overview of that.
Sure. So extreme risk protective order is Maryland's version of a red flag law. And it's actually considered to be one of the better ones in the country. Not every state has one. Ours took effect back in 2017, I believe. And what the extreme risk protective order does is this is a process that doesn't always or often doesn't relate to psychiatric illness. But this is the legal way for if there is a concern that someone is going to harm themselves or other people, regardless of whether mental illness is a factor, then someone can petition a court to temporarily restrict the person's firearm access in order to provide a buffer and really work out the safety issues to minimize the risk that other people would be harmed with that firearm. So if you go to the next slide. There you go. So EPs can be part of an extreme risk protective order process as an option, but certainly many of the people who have been involved in having their firearms removed via the ERPO process were not EP'd because they owned a firearm and that was completely different, or they didn't have a psychiatric illness. And so this is kind of a non-healthcare based intervention for temporarily restricting their access to guns if there's a safety concern. Back when this first took effect, sorry, I think I said 2017, but it was 2018. Most of the ERPOs, as you can see toward the bottom of the slide, are not actually weren't being filed by clinicians. They're being filed by concerned family members or loved ones. But guns in the home absolutely increase the risk of suicide by firearm and homicide. If you go to the next slide.
Or you want the
Can I interrupt you for just a moment? We have a question here in the chat, not related to firearms, but someone is wondering if there's any difference between seeing someone in person versus online in regards to the EP process. So we have a lot of LCPCs and LCSWs on today. And so my sense is that this person's kind of wondering, you know, if you've been seeing someone virtually, does that change the EP process for you at all?
Yeah, great question with telehealth and how prevalent it has been. You're still in that same patient treatment relationship, right? Telehealth, you're still providing a certain standard of care. And so you seeing whatever they're telling you or their mental status exam, it has when you have concerns, it's the same thing as if you were having that same session in the office. So that shouldn't change it. I do though, and let me give my plug about telehealth. Make sure, because many of us don't do it, I'm guilty sometimes too, you need to always know where's that patient located before you start your session. Because if something happens, you know, what if they pull out a knife and are, you know, starting to hurt themselves during that session? You can call 911 in the heat of the moment here, but if you don't know where they are, because yes, you might know their address, but if they're at their aunt's house and this, that, you know, in a different part of the state, in a different, you know, county, you need to know that. So to be able to appropriately direct an emergency response. So telehealth, always remember, don't just assume they're at their home. Most of the times they're not. Make sure that you're asking and documenting that, where's their location. So that's a great question, but it shouldn't matter reflecting the EP process because it's about standard of care, and telehealth right now is you're providing that same set of standards.
Great, thank you so much. It looks like that's the only question right now.
Okay, I just want to, if you want to lead, I thought these charts are always really important when we're thinking of firearms, Dr. Knight.
Sure. Yeah, so this is data from 2020 from the CDC, and I've included the website on the slide. It's a very dynamic website. I'd encourage you to check it out because it's very informative. But this relates back to preventing violence against oneself or preventing violence against other people with firearms. And this slide and the one after it really highlight why it's important. So from 2020, suicide was one of the top 10 causes of death in 7 out of 10 age categories. So people who were, you can see that teal colored square are each of the numbers of people who died by suicide of any method within that age category. So at the very top, each column has the ages that are included in that. So there was a significant percentage of people who died by suicide died via firearm use. And then it stands to reason then with homicide rate, it was also one of the top 10 causes of death for people with a very wide age range. So at age 1 to 54, it was one of the top 10 causes. So there was about 21,000 people who were killed in 2020, and firearms were the most frequently used method of homicide for people who died that were between the ages of 5 to 54. 83% of all homicides were committed using a firearm, which makes using the ERPO even more important, I think.
Yeah. Thank you. I just want to be mindful of the time there and stop sharing for a moment and see if we have any last final questions, comments. We really appreciate and hope. And let us know if you'd like us to come back and give any more detailed in other areas. A lot of this does get confusing at times, and very much so once they hit the unit. A lot of the legal ramifications of what Dr. Knight was describing, we'd be happy to come back and have her return and really dig through some of those details.
Thank you both so very much. We have no other questions right now, but you have multiple compliments in the chat here. Kudos to the presenters. Great job. Extremely informative. Very helpful. Thank you. Thank you so much for an informative training. I want to remind everyone to go ahead and click on our post-training link. It's a survey. You would need to complete that in order to receive your CEU certificate. And Naomi is going to be emailing that out as well. So if you're not able to grab it now, or you're running off to something else right now, we'll make sure and email that out to you to complete. But thank you both so very much. This was wonderful, and it looks like our audience found it very informative.
Well, you're welcome. Our pleasure. Thank you so much.
All right. Thanks, everyone.
Take care. Bye-bye.
Okay.
Thanks, Dr. Knight.
Thank you.